Kentucky, unfortunately, has really been hit hard by the opioid crisis. Around 50,000 overdose deaths every year. Of course, there are a lot of doctors who feel prescribing pain pills would be easier because at a click of a button, they can send that prescription to the pharmacy. And very often the patients are happy, the doctor is happy, and they keep chugging along. And the patients are also more inclined to accept that treatment because when you do take a pill, within 30-40 minutes, you're going to feel pretty good. The unfortunate thing is, along with taking that pill, you can develop tolerance. These patients, unfortunately, end up going down a rabbit hole, and this may open the door up for addiction.
Welcome to the very first episode of the Kentucky Pain Reversal Show, the podcast where science, compassion, and real solutions come together to finally change how pain is treated in our state. For decades, Kentuckians have found themselves stuck in the same cycle: an injury, a prescription, a referral, another test, another pill. And before they know it, months turn into years of chronic pain with no clear path forward. But there is a path forward, and today you're going to meet the physician who spent more than 33 years helping patients break out of this cycle. Dr. Ajith Nair is a board-certified anesthesiologist and fellowship-trained interventional pain specialist who has dedicated his career to one mission: lower the pills, lower the surgeries, and stop the pain at its source. In this first episode, we're starting with Dr. Nair's own story, the moment he realized what pain medicine could be and why he chose a very different path from the pill-first approach that's become so common across Kentucky. Let's dive in. Dr. Nair, before we talk about the pain crisis in Kentucky, tell us about your personal story. What shaped your passion for interventional pain medicine and helping people who seem to be forgotten or feel forgotten by the system?
It's great to be with you today. Well, my story started when I started my residency in anesthesiology at Vanderbilt University. Even though the majority of my training was in operating room anesthesia, we did have a good number of months that we trained specifically in pain management. I was fortunate enough to work with an interventional pain specialist who taught me a whole host of different methods of treating pain other than using pain medication. A number of procedures like epidural injections, facet injections, radiofrequency ablation, and to more complicated and complex procedures like spinal cord stimulator implantation along with pain pumps. These are just a few of the things that I learned from my attending physicians during my residency. Thereafter, I was fortunate to be accepted at an interventional pain fellowship. And there I was able to learn more and hone in on my skills. So that's my, experience and my journey into the field of interventional pain management.
You've mentioned that over your 33 years in practice, you've seen countless patients whose lives were changed by proper intervention. What moment or patient story made you realize, okay, this is the work I'm meant to do, this is my purpose here in this life?
Oh, it's interesting that you should say that. The story that sticks out in my mind was when I saw a 91-year-old lady of Greek descent who was referred to me after having had 6 back surgeries. She was a very frail lady who was taking a lot of pain medication, including transdermal fentanyl along with oxycodone. And she still told me that her life was miserable and that she had no quality of life. Now, after I reviewed her history, I realized that the only thing that I could offer her was to consider an intrathecal pain pump. An intrathecal pain pump is a device that will deliver pain medication directly into the spinal fluid. It is an implanted device, But we first do what is known as a trial, where we give the patient a small test dose of the medicine to see if the patient can benefit from reduced pain and to make sure there are no side effects. So this lady, I was quite hesitant considering her age, but looking at how sad it was that she really couldn't enjoy time with her children and grandchildren kind of made me want to help her and to take a chance on it might working for her. So we went through the trial. She did very well, and we implanted the pump, and she did so well that when she reached her 96th birthday, um, she came into my office and I asked her, what is it that you'd like to see? She said, I want to get through my 100th birthday. And even though she, in the later years in her life, she developed some dementia, she passed when she was 101 years old. And the heartwarming thing is, I'm still in contact with her family, and they had written me a letter after she passed that they were so grateful for the pump that allowed her children and grandchildren to actually experience their mother or grandmother for at least a decade. And so that was really when I felt this work has to be done. This has to be promoted, and it has to be, made so that people who are suffering know that there's a way out.
That's so incredibly special. I actually got chills all over my arms telling that story, that you're, not only are we helping people with their pain, but you're literally giving their families, like you said, a chance to experience them for years longer than they thought they'd be able to, in addition to helping their quality of life. And if they are older, just enjoy what time they have left in this lifetime on earth. That's incredible. You've mentioned that many doctors could do what you do, but few actually do it. Why do you think that is? Why do you think that they choose a different path?
Well, there can be a number of reasons. Now, the skills that are involved, it's a learning curve. And especially with managing a pain pump, it takes a lot of patience, and there's a lot of work that's involved. For instance, let's say a patient has been deemed to be a good candidate for a pain pump. And you go through the motions of doing the trial, the implant, then you have to slowly titrate the medicine to where the patient has good pain control. All of that takes time, and it takes a lot of patience and a lot of patient education. In a culture and society where everybody wants an instant fix, instant results, that can sometimes be challenging. Of course, there are a lot of doctors who feel prescribing pain pills would be easier because at a click of a button, they can send that prescription to the pharmacy. And very often the patients are happy, the doctor is happy, and they keep chugging along. But what I've seen is very often the patient's quality of life is not impacted, and they're still dependent on their medication, dependent on these pills to what they can do in a day. They'll be looking at their clock and saying, okay, I need to take my pill, and then I can do X, Y, and Z.
Mm. And then not only that, it comes to the problem of kind of the epidemic we've seen in the pill area, right? So for listeners, how would you describe the chronic pain landscape here in Kentucky? What do you wish people understood about how widespread and misunderstood pain is?
Now, that's a complex question. Kentucky, unfortunately, has really been hit hard by the opioid crisis. Now, so that your viewers can understand the problem in Kentucky, we have post-COVID, around 50,000 deaths, overdose deaths every year. Now, of those 50,000, over 36,000 are illegal opioid-related overdose deaths, such as associated with carfentanil and heroin. However, the remaining 26,000 odd, they are directly related to prescription opioid overdose deaths. And I believe physicians can make a dent in that number. it involves education. It involves disseminating information that there are other treatment options other than pills. Now, of course, there's a tendency for most people to veer towards the easier way to handle a problem. And as I mentioned earlier, it is easier to write a prescription. And the patients are also more inclined to accept that treatment because when you do take a pill, within 30, 40 minutes, you're going to feel pretty good. The unfortunate thing is, along with taking that pill, you can develop tolerance. And tolerance essentially is the body saying that it needs more of the same medicine in order to achieve the same amount of pain relieving effect. And tolerance will occur in anybody taking opioids. So it's an inevitable problem. However, what I've seen through my experience is that with a pain pump, the tolerance occurs much, much slower. And hence, there's better pain control, and you've got the ability to increase the medication without increasing the patient's narcotic load. So all around, that's great for the patient.
Absolutely. That's so interesting. They don't build up the tolerance. And naturally, we can build up our tolerance to anything, to caffeine, to alcohol, and opioids are just, another one on that list, albeit perhaps much more dangerous and much more addictive potentially. You often describe the ground zero patient, that typical journey that someone goes through when the pain first begins. Can you walk us through what that looks like step by step from the moment the injury happens to the moment they finally find your door?
Sure. Very often your apex patient would be somebody who's probably in their mid-30s, mid-40s, decided to lift a heavy box. They feel a pop in their back, and then they develop this searing pain that goes down their leg, what we call sciatica. It's common that these patients would end up seeing their primary doctor, who will then maybe prescribe an anti-inflammatory, maybe a muscle relaxant, maybe some physical therapy, and hoping that the pain will get better. Sometimes the patients do get better if it's a fairly trivial disc-related issue, but if it's a certain type of herniated disc which causes persistent sciatica, the patient may then get referred to a neurologist. They may be sent to a pain specialist like myself to get an epidural injection, and that itself may solve the problem. However, there are a subset of patients in which this type of sciatica continues, causing debilitating pain and disability. These patients then get sent to an orthopedic surgeon who may decide to do a discectomy where they will remove the part of the disc that's irritating the nerve causing the sciatica. Again, sometimes after the surgery, the patients do very, very well, and end of story. However, again, a subset of patients can develop scar tissue that then transforms into this chronic sciatic pain, which is refractory to physical therapy, injections, and to pain medication. These patients may end up having further surgery, which involves spinal fusion, and they're still taking pain medication and still complaining about out of control pain. That's where I come in with possibility of getting a pain pump in these patients to try and help their pain. Now, again, I want to make sure that your viewers understand that a pain pump is not for everybody. It is for patients that have tried the conservative and interventional ways to control pain, but have failed to get that quality of life back. That's when a patient may be a candidate for a pain pump. What we do in our office is that we'll carefully evaluate the patient, get a thorough history and physical, and understand what types of pain treatment that they've had in the past. Only then do we see whether a pain pump or maybe a spinal cord stimulator or other pain interventional procedures may be appropriate for the patient. That would be the way that I would consider my average patient. Of course, you would have other groups of patients like those who suffer from cancer. Sometimes when the cancer is spread, very often the physicians will keep prescribing oral narcotics. Now, for some patients, that may be great, but side effects also will govern quality of life. Side effects like being confused, feeling mentally clouded, constipation, hormonal changes. These are some of the common side effects associated with oral pain pills. I have seen these patients who doctors have written off saying, okay, now it's time for you to take care of your affairs, and we'll keep prescribing you 400 or 500 milligrams of oral morphine. And if the patient gets to my office and if they are a pain pump candidate, what I've seen is after placing a pump, their quality of life gets better. Now, the outcome of their surgery doesn't change, but whatever time that they have left, they're going to have the ability to express themselves better, enjoy relationships, and I think their overall suffering comes down.
Hmm. Well, it's obviously not a one size fits all solution, as you've mentioned. Everyone is so individual in what they need and what's going to work best for them. But at what point in the patient's journey does the system potentially start failing those patients? When does a temporary injury become chronic pain that takes over someone's life? When should they be on high alert and be like, okay, this isn't just I tweaked my back or I tweaked my neck, but it's something more serious?
That's a great question. So the apex patient that I was talking about, you know, if they did undergo surgery and if they still have sciatica, they're going to try their best to keep chugging along in life, depending on their pain medication. But at some point, when the dependence on these medicines gets out of control, or in a way, it becomes uncomfortable for the physician to write those amounts of pain medication, that's when they may decide to go another route. Maybe they might think about getting things off the street, or they may consider further surgeries, which may not help their pain. So these patients unfortunately end up going down a rabbit hole, and this may open the door up for addiction. So this is a very, I see these type of patients very often also. And again, with correct counseling, correct education, and giving patients an option. And in my case, the option would be to give them the opportunity to have a pain pump trial, where we essentially, it's like testing a car. We give the patient a small dose of that medicine into the spinal fluid, and the patients themselves will get an opportunity to experience what it's like to see a downward trend in their pain. Even at that point, it is up to the patient whether they want to proceed or not. And I respect patients when they say, even if they get good results, good reduction in pain, and if they say, well, doc, I don't think that's the best option for me, I tell patients, I respect your wishes. If you feel more comfortable with other treatment options, I think that's the way you should go, and I support that.
Mm-hmm. Mm-hmm. Well, many people don't know how pain can actually become a neural circuit. Can you explain to us, perhaps in simple language that us normal people can understand, how pain can become wired in the brain and the body, and why that makes it so much harder to treat?
Great question. Now, in order to understand that, we have to know that anybody suffering from chronic pain for more than 3 months, they then start developing permanent circuits in their brain, which recognizes that pain that's in a particular location. Even if there was a way that we could block that pain, the brain still perceives those chronic circuits to still be intact. So in order to get a better idea, let's say we cut our finger. Well, the pain signals from the finger will first travel through the nerves into the spinal cord, and it's going to ascend into the brain where it's appreciated or perceived. Now, let's say if we accidentally burnt our hand over a candle, we tend to pull our hand away. That's a reflex. That reflex doesn't involve the brain per se. It's a circuit that's independent of the brain, and it's a circuit that exists through the spinal cord. But if, let's say, you get burned and there's burning that has occurred onto your finger, that now is perceived in the brain as an area of pain. And if that pain continues for over 3 months, those permanent circuits then develop. And that's very important in the genesis of chronic pain.
That's so interesting. Wow. And is that something almost reminds me of like phantom pain a little bit, if there's been like an amputation almost?
You're spot on, Jamie.
Is that the same thing that's happening in the brain?
It is very similar. These are different circuits, but with regards to phantom limb, the body is mapped in the brain itself. So when certain parts of the body are missing after, let's say, an amputation or an injury, the brain still perceives that part of the limb to be there. Now, over time, there are some changes that will occur. In fact, there's a term that's very commonly used in describing phantom limb pain, and that's telescoping, which means originally after the amputation, the brain still perceives the limb to be there, even though it's not. But as time goes on, as a telescope can be reduced in size, that perception in the brain also occurs, where the limb now will reduce up until it reaches the stump. It does occur over a few months, and it's not immediate, but this is another example of pain circuits that develop in the brain.
That is wildly interesting and enlightening. Very cool. So let's get back to Kentucky. Given everything that you've seen going on in the bluegrass state, why do so many patients end up on pills or perhaps repeat surgeries, but we rarely hear about interventional treatments that could actually reverse their pain?
There are multiple reasons that this occurs. One is that for patients who suffer from chronic pain, they are a risk population. Very often, they can be patients that are in a certain socioeconomic group. And what happens with those patients and their insurance carriers, they would more likely be willing to cover pain medication versus covering an injection or maybe even physical therapy or surgeries. So there is a built-in to the system method where patients are prescribed opioids by mouth readily versus something more interventional or something else that would give better results. So that's one of the reasons. And the second reason is very often when the patient gets about 120 pills during an office visit, they have the ability to use that medicine even though it's prescribed, but they can use it as they please. And sometimes these medicines do give the patient a sense of well-being. And that may be a driving force in wanting to have oral pain medication prescribed.
So it seems like we're getting a couple extra benefits besides just dealing with the pain, or perhaps they even help the pain, but then they keep using them for other reasons. Is that right?
Right. And part of that reason is opioids, and the way they work in the brain is they release a chemical called dopamine. And dopamine is essentially the feel-good chemical in the brain. So any type of addiction can be attributed to dopamine release. And oral pain medications are no different.
Well, let's talk about pain reversal, not just pain masking. What does the pain reversal mean to you, and how is it different from traditional just management of the pain?
Well, I think that any treatment should be tailored to the patient's specific needs. Again, not all patients will need a pain pump or a spinal cord stimulator. Sometimes patients may have arthritic changes in their knee, in their hip, or they may have developed chronic pain from, let's say, a crush injury. So the treatments are very different in all of these cases. I think that cortisone injections can work for a good number of cases, but there are other treatment options. Let's just take knee pain, for example. secondary to arthritic changes. I believe that there are a number of treatment options, such as platelet-rich plasma. This is when we take blood from a patient's vein, we process it so that it ends up becoming full of platelets and a small amount of plasma, and then we re-inject it into the knee or into the hip or even shoulder joints. And essentially the platelets will allow rejuvenation of the cartilage that's arthritic, and it will also reduce the inflammation. So platelet-rich plasma is a good treatment option. Then, of course, there are ways that we can block the nerves that innervate these joints. Sometimes we can actually heat the nerve to inactivate it. That's called radiofrequency ablation, where the nerves innervating a joint can be inactivated with regards to pain. And this treatment can last for about 14 to 15 months, which is enough time for the patients to do other things to strengthen the joint, to reduce pain and increase mobility. So it's a win-win situation all around. Now, of course, then you have patients who will have refractory pain dependent on medications. And this is when, I guess the bigger guns are brought out, like the spinal cord stimulator and the pain pump.
So interesting, but also so inspiring and encouraging to realize there's so many other options for treatment, not only in the management, but in the reversal of the pain than just oral pills themselves. So thank you so much for sharing all of that with us, Dr. Nair. I'm so excited to continue on this journey with you and educating Kentucky and educating the nation about intravenous pain management. So thank you so much for joining us on episode 1 of the Kentucky Pain Reversal Show. Today, you heard why Dr. Nair chose this path, why so many Kentuckians get stuck in long-term pain, and why pain reversal, not just pain management, is at the heart of his mission. If this episode resonated with you, or if someone in your family or someone you love is living with chronic pain, please share this show. You could be giving someone the first real hope they've had in years. Lower the pills, lower the surgeries, and stop the pain. We will see you back here on episode 2.